Dr. Todd, it's your floor.
Thank you very much. Pleasure to start the afternoon off with this important talk. And this is going to be also a whirlwind survey in the next 30 minutes of upper airway emergencies, something we see very, very frequently in the emergency department. I will be using some graphics from Up to Date, and that's cited here. No discussion of upper airway emergencies would be complete without a discussion of how the pediatric airway is unique and different from the adult airway. So we know that children have large occipits, large tongues, that their airway is more anterior encephalad, that their epiglottis is generally floppier and softer. They have narrow cricoid cartilage, and their airway is more funnel shaped. And as a result of all these considerations, this unique layout of the pediatric airway is really what predisposes them to some of these upper airway emergencies that we will talk about. And what I'd like to start with is talking about what is the progression of upper airway obstruction. So we'll start with upper airway obstruction. Generally, if there's mild obstruction, child can still speak, they may have hoarse voice, air entry is good. This child might have inspiratory stridor with minimal to no work of breathing. So that's really mild obstruction. Moderate to severe obstruction, you start seeing more work of breathing, tachypnea. This child is having inspiratory stridor with every breath, right? So this is the kid with moderate to severe croup, where they are stridulous with every single breath, whether they're sitting at rest or crying. And these kids will also have prolonged inspiratory times with work of breathing. And in severe cases, they'll assume the sniffing or tripod position, because what they are trying to do is physically open their own airway through that positioning. With complete airway obstruction, there is no air movement. Distress is severe, and importantly, it is silent. They cannot make sound if they have complete airway obstruction. And so just because they're not sounding like they're choking does not mean that they aren't in fact choking. So let's start with the most extreme, which is a complete airway obstruction, typically from a foreign body, right? So this is our first aid, our very basic, what we learn at the very beginning. Usually that obstruction occurs, due to a foreign object at the larynx or the trachea. It presents with aphonia, distress, stridor, and retractions. In infants less than 1 year, our approach is a series of 5 back blows, followed by turning the baby and 5 chest compressions to try to expel any foreign object. And then after that, you observe to see if you can see the foreign body or not. If not, you continue with this series of back blows and chest compressions. Greater than 1 year, we do abdominal thrusts, also called the Heimlich maneuver, as a means of trying to clear a complete airway obstruction. Again, if the patient can speak, they are not fully obstructed. So you should not start these maneuvers in a patient that it can speak at all. If they are aphonic and in distress, that is the time to initiate these. And do not blindly sweep into the mouth. So if you cannot see the object that is there, don't put your finger into the mouth, because you risk pushing an object that is further down even further into the airway and worsening that obstruction. So this is an algorithm. This is an algorithm that we can use. We start with back blows. If there's relief, the next question is, are they breathing spontaneously? If they are, you want to ensure that you have complete resolution of the foreign body, and you want to observe for some degree of time, because you can have post-obstructive pulmonary edema as a complication of complete airway obstruction. If there is not spontaneous breathing, you want to breathe for them with bag valve mask ventilation, thinking about rapid sequence intubation, and again, ensuring that the foreign body is removed. If there is no relief with back blows or chest and abdominal thrusts, then you want to try to visualize the object using direct laryngoscopy. And so you're going to do direct laryngoscopy with McGill's forceps at the ready. And if you can see the object with direct laryngoscopy, you go in with the McGill's, grab the object, and remove it. If the foreign body is removed at that point, you can do supportive care. You want to ensure that foreign body is removed, and you want to observe for post-obstructive pulmonary edema. If the foreign body is not removed, it now depends where the foreign body is in terms of your next steps. If the foreign body is above the cords, this is the one rare situation where you would consider doing a needle cricothyrotomy. As Dr. Auerbach stated yesterday, this is not a procedure that we should be doing nearly at all, but this is one situation. If you have a full obstruction that seems to be above the vocal cords and you cannot clear that obstruction, you need a way to get air in, and a needle cric is the easiest way to do it. If the foreign body is below the cords, you're going to actually want to intubate, and you're going to want to intubate deep. So you're going to want to take the tube and push the object and intubate into the right main stem so that you are pushing the object into the right side so that at least the left side can then ventilate and oxygenate. So you want to advance it. Then that patient then goes to the operating room with ENT or pulmonology for a bronchoscopy and removal of the foreign body at that time. So that's foreign body, complete airway obstruction. Rare situation, but this is the life-threatening immediate situation. Indications for needle cricothyrotomy: if there's massive facial hemorrhage, complete foreign body obstruction, large oropharyngeal edema, airway obstruction, severe laryngospasm, severe facial fractures, or failures of oral intubation in extreme cases. But for the most part, this is a last resort maneuver and should not be something that we are doing on a regular basis. If you contraindications for needle cricothyrotomy are if you are having a concerned about distal tracheal transection, so in the case of trauma, penetrating trauma to the neck, with a low tracheal obstruction, significant damage to the cricoid cartilage, if you have difficulty identifying your landmarks, or if you have a coagulopathy that could then lead to increased bleeding into the airway. These are the contraindications. And certainly the complications are bleeding, tube misplacement, inadequate oxygen or ventilation, aspiration, infection, barotrauma, or damage to the vocal cords. And just to go through our anatomic landmarks, if we look at diagram A, this is an airway of an older child or adolescence. You're going to find the prominence, the laryngeal prominence of the thyroid cartilage, and work your way down to look for that cricothyroid membrane. Let's see. Oh, it's not quite. Oh, there we go. That's not quite working, but you can see where it's pointed out there. In an infant, this laryngeal prominence of the thyroid cartilage is not as prominent. And so you start at the bottom, you feel the cricoid rings, you work your way up to the end of the cricoid rings, and that's where you're going to find the cricothyroid membrane, where you're going to approach. And you want to go midline to avoid the cricothyroid artery, which can lead to significant bleeding. You take a syringe that's attached to an IV catheter with some saline or water in the syringe. You're going to stabilize the trachea, insert at a 30 to 40 degree angle until you see bubbles. That's why the saline or water is in the syringe. You see bubbles, you know you're in the airway. You withdraw, you leave the IV catheter there and advance it to the hub. And then you can do some jet ventilation through gentle bag valve ventilation through that airway until you can get that patient definitive care by ENT. More often than not, if there's an obstruction, it's going to be a partial airway obstruction. And a history of choking is about 90% sensitive. The classic triad on the boards that we think about for partial airway obstruction due to a foreign body is wheezing, cough, and diminished breath sounds. However, that triad is only present in about 50% and has a low sensitivity. So you really cannot rely on that triad being present when thinking about a partial foreign body obstruction. You should have high suspicion when a foreign body aspiration is witnessed, if there's a history of choking, or if there's a young child with suggestive symptoms without any other explanation. You cannot rely on normal chest radiographs. So traditional teaching for foreign body aspiration has been you do an AP, lateral, and decubitus films. And then the side that's down, you should expect that the mediastinal structures would then push down on that lung. In a case of an obstruction, you have air trapping and you don't get that depression of the mediastinal structures on the side that's down in a decubitus film. Now, more recent studies have shown that you actually cannot rely on decubitus films 100%. If the history is high enough, it doesn't matter what the decubitus films show. You're calling otolaryngology for exploration and bronchoscopy in the operating room. Also, it really should be regardless of imaging because in high suspicion cases. So that's the more emergent, complete, when we're talking about upper airway obstruction. When we think about upper airway emergencies and formulating a differential diagnosis, I like to think of it in two categories, infectious and non-infectious, because the approach is going to be quite different. And then within each of these, we think of acute and chronic. So infectious diagnoses. So one of the most common acute is croup. I like to say that we have a new diagnosis for 2022, and that's COVID, croup due to COVID. We also think about epiglottitis, bacterial tracheitis, diphtheria, which I am free to admit that I've never in my life seen diphtheria, except for on the boards. Retropharyngeal abscess, which I have seen quite often in my life. Peritonsillar abscess, Ludwig's angina, and infectious mononucleosis due to Epstein-Barr virus. And then chronic infectious diagnoses include adenotonsillar hypertrophy and chronic tonsillitis. Our non-infectious diagnoses, acute, include foreign body, angioneurotic edema, penetrating or blunt trauma, burns, vocal cord paralysis, and vocal cord dysfunction. Our chronic non-infectious diagnoses include choanal atresia or stenosis, laryngomalacia, tumors, rings and slings, vascular rings, subglottic stenosis, and craniofacial abnormalities such as that infant with Pierre-Robin that we saw during yesterday's talk. So as I'm breaking down this differential diagnosis into these sort of infectious, non-infectious, acute, chronic categories, I'm thinking about diagnostic clues of the child that's in front of me. So a child that presents with sudden onset, quick stridor, with nothing preceding, you're thinking about either foreign body or anaphylaxis. Generally, kids with croup, the parents will say that it was a quick onset, but it's not going to be, they were fine 1 minute, and then all of a sudden, while awake, they just started having stridor. If they're toxic appearing with very high fevers, we think about these some of the more rare diagnoses like epiglottitis and tracheitis, but also peritonsillar and retropharyngeal abscesses. Kids who are drooling and maintaining in the tripod position to try to open their airway, we think about epiglottitis, retropharyngeal abscess, and diphtheria. Muffled voice, that's sort of that hot, we call it the hot potato voice, and dysphagia, we think about peritonsillar abscess, retropharyngeal abscess. If there is lip swelling and a pruritic rash, we think about anaphylaxis or angioneurotic edema. Bleeding or bruising, certainly trauma or hematologic issues or malignancies. Prematurity with history of intubation is a major clue for subglottic stenosis. And this is very common. We all know this in general pediatrics. If you have intermittent stridor that improves while prone, we think about laryngotracheomalacia, particularly in the young infants. So stridor, large differential diagnosis that's listed here. We've already talked about many of these. Let's start with croup, which is really one of the most common causes of upper airway obstruction. Generally, it's 6 months to 6 years. It can be older. I've seen 8, 9, and 10-year-olds who have presented with croup. But generally, if you remember the sixes, that's the board question, 6 months to 6 years. It is always viral. Parainfluenza type 3 causes the vast majority. That's the board answer for croup. But we do know that croup can be caused by a whole host of viruses, including flu, adenovirus, and RSV. And now COVID. It's a clinical diagnosis. We should not be routinely obtaining chest radiographs for children who present with routine croup. The children where chest x-ray is, an airway film is helpful are kids where there may be an other diagnosis or kids who are not responding to treatment the way you would expect them to respond. So probably the most critical alternative diagnosis that you need to rule out is a button battery ingestion for croup, which can lodge here, cause stridor, can mimic croup. Generally, those kids are not going to respond to croup therapy. And those are the kids that would need imaging to check for an alternative diagnosis. So that one sticks with me because when I was a fellow in training at CHOP, and Dr. Mittal may remember this case, there was a case of a child who was treated with croup and went home and came back because they were not responsive and ended up having a button battery with significant aortotracheal, aortoesophageal, right, thank you, fistula. I had a little word finally, and that child actually bled out and died as a result of that complication. So those are the kids where you're going to think about radiology. If you do get it, you see here the classic steeple sign where the airway comes to a point at the top of the airway. And the management of croup is supportive care. So we traditionally tell parents, turn on the shower, hot water, steam up the bathroom, bring the child into the bathroom and let them breathe in the steam, or go out for a drive in the cool night air and let that help. Generally, these measures, they're not evidence-based, they're not shown to work, but they give the parents something to do to help calm the child down, which is ultimately what you really need to do, is calm the child down. Dexamethasone is the mainstay of therapy. It can be given orally or intramuscularly if the child's not tolerating oral medications. It is a single dose. 95% of kids will respond with a single dose of dexamethasone. Some kids may come back 2 days later when the initial dose is worn off and need a second dose. Racemic epinephrine is the mainstay for moderate to severe croup. Usually we give it to patients that are in significant distress or that have stridor at rest. We don't give it to the kids that have stridor when they're crying, but when they're at rest, they're looking at baseline. And then if severe, you can consider using Heliox, which is that 70%, 30% helium oxygen mixture that can help increase laminar flow, decrease turbulent flow in the upper airways. Criteria for admission for croup are if after doing 2 racemic epinephrines and dexamethasone and a period of observation, they have continued audible stridor at rest, if they have a toxic appearance, dehydration and vomiting, or respiratory distress. And if, the Westley croup score, I don't have a slide on this, but that is really the most widely used croup score to help gauge progression to more moderate or severe illness requiring hospitalization. A word about COVID. This study was just published, and as you can see here, with the Omicron variant, we had a really steep increase in the presentation of croup, which you can see here in the sort of far right side of this graph, is that because Omicron variant had a predilection for the upper airways, it caused a croup-like syndrome in kids. Actually, that is how my 10-year-old presented. He woke up one morning, he had croup sounding cough, and I said, put my mask on, I said, you've got COVID, and sure enough, he did. In terms of epiglottitis, moving on. This is extremely rare. I have not seen it in my career. It presents with an acute onset of high fever with rapid deterioration. Traditional etiologies include Haemophilus influenza, staph, and strep. And the way to remember this for your boards is the 4 Ds: drooling, dysphagia, dysphonia, and dyspnea. And if you have those 4 things, generally these kids are looking really sick and they are tripoding, and this is really an infectious emergency, a true infectious emergency. This is the radiology. If you do a lateral airway film, panel A is the normal epiglottis, and you can appreciate it. It is, you can see the hyoid bone there, and immediately posterior is the epiglottis. It's pretty thin. It's not juicy or, swollen. And then look at panel C. That is epiglottitis. That is a hyperemic, juicy epiglottis. That is more concerning for epiglottitis. So the initial airway management for epiglottitis is, the first question is there total or near total obstruction? If the answer is no, then your next step is to assemble your team. Epiglottitis is the diagnosis where you want the most experienced airway providers providing care to the patient. And sometimes that means calling our anesthesia or otolaryngology colleagues. You want to get the team together. You then want to ask, is the child less than 6 years old, or is there more than 50% obstruction? If the answer is yes, then you proceed to endotracheal intubation in a controlled setting with ENT available for a rigid bronch or surgical airway, given the propensity for this leading to complete airway obstruction. If the answer is no, it is reasonable to get cultures, admit to ICU, and start on antibiotics. Now, excuse me. If there is total or near total obstruction, then you start doing bag valve mass ventilation with 100% oxygen, and you have a stat page to get your airway team to the resuscitation bay. If they are not maintaining oxygenation, there is a single attempt at endotracheal intubation by the most experienced person while ENT is prepping or surgery is prepping for a surgical airway. Extraglottic devices like LMAs should not be used in epiglottitis to secure the airway, because they can actually worsen the airway obstruction. If you are unable to get an ET tube, that is an indication for a cricothyrotomy. If you are, then cultures, ICU, and antibiotics. And if this patient is maintaining oxygenation, then there is time to go to the operating room for a controlled intubation. So that is really the management pathway for epiglottitis. Tracheitis, bacterial tracheitis is a related diagnosis. It's rare. It generally occurs in the first 5 to 6 years of life. Oftentimes, it's a complication. It starts as a viral upper respiratory tract infection where you then have super infection with a bacterial cause that leads to tracheitis. Staph aureus is the predominant organism, but Strep pneumoniae, Morax salicateralis, and Haemophilus influenza are other organisms that can lead to this. Most of these kids start with a 1 to 3 day viral prodrome, and then they have they get secondarily infected with stridor, dyspnea, and look pretty toxic. A few can start with sort of a fulminant onset, looking toxic, having fever, and then certainly we talked about the signs of airway obstruction. It's a presumptive diagnosis. You would presume this diagnosis with the acute onset of airway obstruction, high fevers, toxic appearance, and if you try nebulized epinephrine, a poor response. And on X-ray, here you can appreciate an edematous, sort of ragged trachea on lateral airway film that makes you suspicious for the diagnosis. This is another diagnosis that can progress very quickly to a complete airway obstruction. So a prompt ENT consultation, supplemental oxygen to maintain oxygenation, fever control to try to decrease the child's metabolic demand, fluids, comfort. This is the classic case where you don't want 55 people in the resuscitation bay. You want to try to clear out the resuscitation bay and calm the situation down. Just step away from the child as best you can. Antibiotics for bacterial tracheitis include vancomycin and a 3rd generation cephalosporin or Unicin, ampicillin, sulbactam. Intubation if needed, and possibly bronchoscopy as well. So now moving on to conditions that are less emergent, but emergent nonetheless, and this includes retropharyngeal abscess. These are most common in kids less than 6 years of age, where Waldeyer's ring of lymphatics extends into the retropharyngeal space that is not involuted yet. It's generally polymicrobial in nature and presents with fever, sore throat, neck pain, torticollis, and drooling. And in terms of imaging, if you have concerns, on the lateral neck film, the diagnostic criteria for a retropharyngeal abscess is a prevertebral space that is greater than half the diameter of C1 or C2 vertebral body, or 7 millimeters. And here you can see thickening of the prevertebral space in the radiograph. If we look at the CT, you can see the abscess labeled B is the retropharyngeal abscess with an associated parapharyngeal abscess that is labeled A. Generally, if there's severe obstruction, you secure the airway, as we've been talking about throughout. CT neck with contrast is the diagnostic standard for retropharyngeal, parapharyngeal abscess. If there is an abscess that is greater than 2.5 cubic centimeters, then that requires surgical drainage followed by IV antibiotics. If it's a phlegmon or a smaller abscess, it is reasonable to admit the child to hospital for a trial of antibiotics and reassess at 24 to 48 hours. If there's no improvement, repeating the image. If it's grown, at that point, the surgeons may go in and drain it. We want to cover our anaerobes, anaerobic organisms. So we would start with either ampicillin, sulbactam, or clindamycin as our first-line empirical IV therapy for retropharyngeal abscess. Here we see a very large peritonsillar abscess. This is more common in school-age kids and adolescents. They are less predisposed to a retropharyngeal abscess because that Waldeyer's ring has involuted. And so we see peritonsillar abscesses much more commonly, and it typically follows a course of acute tonsillitis. This presents with sort of the classic hot potato voice. You can have some drooling, some trismus, dysphagia, severe sore throat, and fever. And for peritonsillar abscess, you see the uvular deviation. So this picture here is not subtle, but it gives you the idea that you see this bulge. It's shiny. There's no wrinkling of the sort of peritonsillar space. And that's indicative. You can see some hyperemia with the blood, with vasculature there, and that's suggestive of an abscess. If there is a probable peritonsillar abscess in a cooperative patient, ENT or emergency physicians can actually drain them using needle drainage. With the mouth open, insert the needle, pull out the pus, and you can drain it, do incision and drainage or needle aspiration right there in the ED. If it's peritonsillar cellulitis without abscess, you're going to start with antibiotics, and you do want to make sure that you include anaerobic coverage in that empiric treatment. If it's suspected, you can't quite tell if it's a peritonsillar abscess, but you're suspicious, it is reasonable at that point to do a trial of IV antibiotics and pain control with hydration, and then can consider imaging or drainage if there's no response. And again, amsulbactam or clindamycin, add vancomycin or linezolid if there's no response to initial therapy. There's controversy in the literature as to whether corticosteroids are effective in the treatment of RPA or PTA, and I think the jury is still out a bit. We published a paper using administrative data, of 40 plus hospitals that are part of the Children's Hospital Association that showed some benefit to averting operative intervention if corticosteroids are started early, but that is limited by the fact that it's administrative data, and there's some confounding to deal with that. So the jury is still out on corticosteroids in PTA. And then to end, through this whirlwind tour, we think about other upper airway conditions such as trauma or burns. So facial trauma or burns to the face or neck, airway management is critical. Early intubation is something to think about because you can have rapid obstruction develop as a result of this. The traumas and burns that have a high risk for progression are burns and penetrating trauma. The classic finding that we talk about is soot in the mouth or in the airway as something that should make you think about an early intervention. And your options include intubation, cricothyrotomy, or tracheostomy. And then anaphylaxis, we've talked about a bit throughout this conference. IM epinephrine is the hallmark of treatment with corticosteroids and histamine blockade, and thinking about intubation or an LMA if there's airway compromise. And with that, I will end and hand it over to the next speaker. Thank you very much.